Thank you very much for this kind introduction. I'm Magdalena Skipper, Editor-in-Chief of Nature. It's a real pleasure to be here. I've really enjoyed this morning's session, and I will be moderating the next panel entitled Ensuring Accountability, Women in Research, Healthcare and Policy Leadership. We have quite a wide-ranging scope, but before I move on to the panel, before I introduce our panelists, let me take a step back and really lead off where Mala left, talking about this world in which women everywhere lead happy, healthy and fulfilling lives. You know, the Summit of the Future is just starting, is just taking place now. And if you read the Pact for the Future that was adopted by United Nations on Sunday, you would have seen that Action 8 states, we will achieve gender equity and the empowerment of all women and girls as a crucial contribution to progress across all the SDGs and targets. And yet, right now in Afghanistan, there is a really horrendous humanitarian crisis taking place. Children are dying of completely preventable and curable diseases and of severe malnutrition. And a great deal of reason why this is happening is because there is no opportunity for international aid to get directly to women, who of course would then get directly to children. Not many media institutions have access to the ordinary people in Afghanistan. The BBC is one of them. They just completed a really harrowing report, women reporting 6 out of 6 their children dying from malnutrition. Now, why am I saying this in the context of the UN? It's because nobody is really initiating serious talks with the Taliban about restarting education and bringing back women into the rightful place in the society that they have. I think that's talking about action points, as we were asked to do. I would like to propose that we all petition for that to change. And the conversations with the Taliban are taking place, just not about this, in my view, a really crucial issue. And this, incidentally, is very relevant to the title of the panel, Ensuring Accountability. So one of the things I'd like us to consider, both you as the audience, but also our panelists, and of course by you, I mean those of you in the audience in the room here, but you online, is what does accountability mean? Who is accountable? And who should hold whom accountable for what? I think these are important questions to consider. So we had a great deal about inequalities. We also had a great deal about progress. Despite much progress, women's health and well-being remains understudied and underfunded compared to other issues. Let me just give you an example. So we're talking about health here from a medical perspective, but let's consider it from a technology perspective. So some examples that I'll share with you to start off with are very well established now and often talked about. So of course the issue of the design of crash test dummies, which continues to mean that women suffer greater bodily harm in the case of car crashes and collisions. Provision of toilets. This place is quite unusual in the sense that it has all gender toilets, but usually wherever you go, there is the same number of toilets provided for men and for women, even though women more often are taking care of children and often have other reasons that we already discussed for needing these provisions. Voice recognition is designed for tones lower than for most women. Similarly, design of furniture. Body armor design, which means that for Those individuals, for example, in the police or the army, often women sustain greater injuries. Similarly, hazard design, equipment design, room temperature setting often is too low for women. As a European, that's something I suffer from a great deal when I come to this country. Design of hand tools. Standard bags of sand and cement are often way too heavy for women to deal with. Similarly, gadget designs are more often designed for larger male hands than for female hands, for women's hands. And also app design. For example, until recently, Fitbit failed to track movement if you were pushing a pram because your arms were stationary. So just a few examples, and of course we know we can trace these issues at least in part to the fact that often those who are around the designing table do not include women, to whom it will be obvious that these design considerations would need to be taken into consideration. We talk a great deal about collaborations here. Let me share with you some statistics around collaborations in academia in particular, which is relevant to a number of topics we'll be discussing here in this panel. So large-scale administrative data on research teams, team scientific output and attribution of credit show that women are significantly less likely to be named on a given research article or patent produced by the team relative to their male peers. An extensive survey of authors has shown that women's scientific contributions are systematically less likely to be recognized, and qualitative responses suggest that the reason that women are less likely to be credited is because their work is often not known, is not appreciated, or is ignored. And similarly, in terms of authorship, 10% of corresponding authors preferred not to disclose their gender in research articles. And those who do, and this is data from Nature Portfolio journals, 17% identify as women. And just by comparison, women make up almost 32% of all researchers globally, according to UNESCO data from 2021. So 32%, and yet women make up 4% of corresponding authors of known gender from Japanese institutions. So of course that cross-sectionality across gender and location is particularly stark in some cases. Just for comparison, for China, that's 11%, for the US, that's 22%. There is some evidence to also suggest that there is gender bias in peer review of research. So just some statistics from across science publishing, which of course is my daily life, but also from real life. I gave you some examples of design. So we're going to talk about ensuring accountability in research, women in research, in healthcare, and policy leadership. So I'd like to invite my panelists to come and join me on stage. Please come and join me. I have wonderful Janine is coming up now. I have Dr. Janine Austin-Clayton, who is NIH Associate Director for Research on Women's Health and Director, please take a seat, Director of NIH Office of Research on Women's Health. She is the architect of the NIH policy requiring scientists to consider sex as a biological variable across the research spectrum. This is part of the NIH's initiative to enhance reproducibility, rigor, and transparency. And she's co-chair of the NIH Working Group on Women in Biomedical Careers. She also leads, more broadly, efforts to advance women in science careers. I should say that at Nature, in the Nature portfolio, we require our authors to disclose whether sex and gender, in our case, were considered in study design where it's relevant to the research that is being reported. Our other wonderful panelist is Carolyn Harris, who is Labour MP, member of the UK Parliament. She's the MP for Neath and Swansea East. And Carolyn has been a long-standing campaigner for women's health, championing menopause in the House of Commons, and speaking on health equity and access at the UN. We'll hear a great deal more about this from Carolyn. But first, I'd like to invite Janine to share her perspective from the NIH's perspective, please.
Thank you so much, Magdalena, and thank you for the organizers, ECH Alliance and the Society for Women's Health Research. I'm excited to be here and looking forward to share a couple of thoughts with you before we go into our panel. So if you could tee up those, there we go. Some disclosures there. And our session is about accountability related to care, policy, and delivering that care in the context of policy. You heard a great deal this morning about maternal morbidity and mortality and data, and I often begin my presentations with this US comparison to other high-income countries because it represents why I do what I do. We always start with the data at NIH, and the data are clear that maternal mortality rates are higher for the US, and they're higher for certain populations, Black and African Americans, than others, despite the fact that we've supported research that has brought new technologies that helps us to understand the underpinnings of diseases like preeclampsia. We still have work to do to get that research and those results to every woman that needs it, everywhere that she needs it, and to make sure that we get high quality care delivered to everyone. So that's our why. And then worldwide, of course, we know that there are women's health care disparities everywhere. And you heard about that this morning. As a result, there are gender equity is an issue worldwide because of those care disparities. So when we think about women's health, it is reproductive health, but it is so much more. So I'd like for us to think about saying the health of women to help everyone understand that women's health is reproductive health, maternal health, and everything else that affects a woman from head to toe, inside and out, across her entire life course, menarche, menopause, and beyond. And we know that to have healthy people, we need a whole person approach. We need to take that life course perspective, and we have to consider sex, biological and gender, social and cultural constructs in our efforts. Worldwide, people experience disease differently, and that you don't need to read anything on that slide just to say that for males and females, it's different. And in order for us to do better by everyone, we need to make sure our education includes consideration of those differences. Our care is sex and gender aware and informed and delivered in a way that's personalized, because indeed, personalized means we're paying attention to the person, and that informs our policy and everything we do. So I'm going to divide my remarks about the Office of Research on Women's Health, or ORWH, and the National Institutes of Health, or NIH's efforts around accountability in terms of policies, practices, and programs. Little historical context in the United States: it was not until 1993 the NIH Revitalization Act was signed, which requires that NIH-supported clinical research include women in those studies. And then the 21st Century Cures Act of 2016 reaffirmed that information and then talked about how important it is to account for sex as a biological variable. At the Office of Research on Women's Health, I'm honored every day to work with the 27 institutes and centers, leadership, scientists, program folks, everyone on the ground, to expand women's health research, make sure that women are included in those studies and to advance women in STEM, because we envision a world where sex and gender are integrated across the entire health research continuum, and a world where every woman receives evidence-based diagnostics, treatment, and care tailored to her own circumstances, goals, and needs, and a world where all women in science reach their full potential. So how are we going to get there? Inclusion, as I mentioned, and women being included in studies is part of our raison d'etre. It's in our DNA. And why might that be important today? Most recently, in the 21st Century Cures Act, we now require investigators who receive NIH funding to put the results of those phase 3 clinical trials, those big studies that inform our care, put those results into a website called clinicaltrials.gov in a way that is disaggregated by sex or gender, race, and ethnicity, so that publicly funded research results will be available to the public and inform your care and mine. Because we know that inclusion is important to support rigor, reproducibility, and certainly generalizability of those clinical study findings. For whom do those results apply? And we do this through collaboration, as I mentioned, and we're pleased to announce we recently issued the new 2024 to 2028 NIH-wide strategic plan for research on the health of women. And we do this through collaboration, where we develop workshops, funding opportunities, and set the research agenda. You heard in my introduction about the NIH policy, and here's what it is in a nutshell. We expect that sex as a biological variable will be factored into research design, analysis, and reporting for vertebrate, animal, and human studies, and that strong justification from the literature or data be provided for applications proposing to study only one sex. That's this policy in a nutshell. Why was that necessary? Because really in biomedicine, we had a default. And the default in our mind was a 70-kilogram man. And there was an understanding, or a conception, should I say, that what was fundamental in biology was what was shared, not what was different. And so the focus was on fundamental biology in that way, with predominant inclusion of men in studies, predominant inclusion of male animals in animal work. So that's pretty unidimensional. And as a result, we have gaps in our knowledge today about female biology, pathology, and pathophysiology. And so it's important to account for sex as a variable from the preclinical space, which is indeed preclinical. We're declaring we're going to the clinic. You have to think about women's health, because you need to be beginning with the end in mind if we're going to get to personalized medicine centered on the person. And disaggregating results by sex is important. You might say it's not really that important. It's not going to be that different. You know, you're making a big deal out of something. It is a big deal. And here's why. So that graph shows aggregated results from some treatment in the magenta color compared to standard control in the blue color. And if the results were not disaggregated, which they are in those subsequent male and female columns, you would not see any effect. You would discard this as a potential treatment. You would miss an opportunity for innovation. Unfortunately, this particular example is real data, and it's about a treatment potentially for stroke. And this intervention, PJ34, you don't even need to know what that is, it decreased the stroke area, which is good for the male mice in this animal model of a human disease, and it increased the stroke area, worsened for females. That's important for us to know. It doesn't mean we're going to discard it. It means we need to know what's beneath that so we can develop appropriate treatments. And we wouldn't have known that. So I call that data hiding in plain sight. And biomedical papers have highlighted the differences between many, many diseases, such as autoimmune diseases, which are much more common in women than in men, shown on the right, and the need to integrate that perspective considering sex, anatomy, biology, chromosomes, hormones, traits, physiology, as well as gender, that both affect. And this article by Franck Mauvais-Jarvis highlights recommendations to the entire biomedical enterprise about promoting sex and gender equity. And included there are issues around journal editors and publishing, and I'm so pleased that the Nature Group has advanced that inclusion in their standard procedures. WHO recently adopted the Sex and Gender Equity and Research Guidelines, and the International Committee of Medical Journal Editors recently amended their content to encourage authors to refer to the SAGER guidelines. And it was my privilege to work with my colleagues in the nursing field to recently publish a paper in Nursing Outlook on the importance of this in nursing and nursing science. But I often have to speak to, and am privileged to speak to, lay audiences about what I do, and I don't lead with SABV. I talk about how important it is to address these 4 C's, and I think all of us need to be able to communicate about what we do to everyone who we might encounter, considering why being male or female might be important before you begin the study, collecting the information in a way that you can report it and characterize it, and then communicating that difference when you speak about it. So these are the 4 C's of studying sex to strengthen science. The ways we do that across NIH are cross-agency efforts, making sure that we have a number of women's health researchers through our Building Interdisciplinary Research Careers in Women's Health, or BIRCH program, setting the research agenda and focusing on programs that make a difference. Here's one program that makes a difference. We lead with our 7 institutes and centers that partner with us, NIH's only program, center level, looking specifically at sex differences in health and disease to inform and improve the health of women. We cover many, many disease categories listed here. We also bring attention to data, and we pull it together in a way that illuminates our gaps. The understudied, underrepresented, and underreported populations, or U3 populations, we bring that into focus every 10 years when there's a new US Census, and we highlight the data so you can see the differences among populations of women, because often the data are only disaggregated by sex or race and ethnicity, but not both. So that's important for us to understand race and ethnicity differences, as well as geographic differences related to rurality or urban locations. We create curricula through our Gender R25, which we just had our first meeting on, either addressing sex and gender and neurology here, or healthcare equity in OBGYN or obstetrics and gynecology, and we have several other interprofessional educational materials available online. We've been investing in the health of women since the beginning, but certainly since the 30+ years that ORWH has been there, from the landmark Women's Health Initiative to our current efforts, including the formation of a new office on autoimmune disease research within ORWH, and our more recent efforts focused on innovation. And you heard from Mala Adiga the importance of the White House Initiative on Women's Health Research to highlight and accelerate progress and fundamentally change how we approach and fund women's health research in the United States. And here's one of the ways we are doing that at NIH. We created a notice of special interest, which is essentially a rider, something you attach to other things. We attached it to all of our standing funding opportunities, those that are on the street, available right now, for research grants, for career development grants, for fellowship grants, and for small business grants. Then you can see on the right, that resulted in a number of additional opportunities with a total of over 400 unique pathways to get women's health research funding. We expanded the mechanisms, we expanded the topics, and virtually every single institute and center eligible for this signed on in record time. And I'm so thrilled to share that with you. That QR code will take you to that notice of special interest. These are the topics that are addressed there, and you can see that they're the topics that we talk about all the time. We cover the gamut. There are over 175 specific priority topics that the institutes called out of interest. And we made a commitment to increase our small business innovation and tech transfer investments by 50%. We created at the Office of Research on Women's Health website, which is www.nih.gov/women, a single front door to access all of NIH's women's health research funding opportunities. And we committed to funding a Pathways to Prevention series on menopause. We only pick one per year, and we picked menopause this year. So kudos to NIH leadership for making that decision, and my colleagues. And I was so excited to see my colleague, Dr. Rucheg, speaking this morning about the Women's Health Opportunity Map. It was amazing to have over 250 folks representing 50 countries together at NIH, highlighting what they thought were the most important and high return R&D opportunities, and there are 50 highlighted in this map, with women's health and well-being at the center. And I'm just going to highlight a few on data and modeling. I want you to take a look at those gaps. We need to harmonize our data so we can report more granular data. We might need to have common data elements that are specific for women. What about menopause status? That is salient to the women's data. In terms of research design, we need to make sure that we advance sex and gender intentional approaches. And I'm not going to read the others because I want you to go to that opportunity map and look at them for yourself. So the Office of Research on Women's Health at the National Institutes of Health is working every day to advance the health of women. We're trying to expand rigor of our research to address women by accounting for sex as a biological variable in our review, publications, and programmings. We're encouraging and requiring, in some cases, the disaggregation of data by sex and on multiple domains, because we know that at its best, research and policy go hand in hand. Because we want to do that, we're supporting innovative policies and programs to address the needs of women, because, as everyone in this room knows, when women's health improves, the health of communities and societies improve. And you can check out all of our materials here, and I'm really looking forward to our panel discussion today. Thank you so much.
Thank you very much, Janine. I now want to invite Carolyn, but before I do, I want to link up to the previous panels in which we talked about communication and involving society. And the link here, you finished with examples supporting research into menopause, which we know is severely understudied. It's a perfect segue. Let me insert my own example. When my mum told me that when she started menstruating, she had no idea what was happening to her body, I was shocked, and I thought, how can this be that somebody would, come to their early teenage years and not know what would be happening to their body? And guess what? And then my menopause came, and I had no idea what was happening to my body. So what I would like to suggest is that with the generation, we made progress on the sort of start of the reproductive cycle, but we have a great way still in which to catch up on the end of reproductive cycle. So Carolyn, you spent a lot of time campaigning for research, for awareness. Please tell us your story, and how does it work in practice in the context of the UK Parliament?
Okay, well, I can beat you on that one. When I was much younger, my aunt and my grandmother, and my two aunts and my grandmother were talking about one of my aunt's health condition. And when I walked in the room, they asked me to leave because I was too young to know what they were talking about. I was 37 at the time. But that just goes to show that there's a whole taboo around. We don't talk about periods, we don't talk about menopause. Well, I'm really, really pleased to say that in the UK, whether it's on national TV, whether it's in the House of Commons, wherever I go, actually, and my icebreaker is vaginal dryness. It works every time, but we have got the menopause as a national conversation, and it's very much my hope that it becomes a global conversation. But to tell you how we got to where we are and where we are, I have to tell you a little bit about my story, because I think I am, maybe not the circumstances of my story, but certainly the mindset of my story. In 1989, I lost my son Martin in a road accident. At the time, I was a dinner lady and a barmaid. And I just didn't exist for about 3 or 4 years later. My life came to an end. The only way that I could actually get myself back on track was to keep busy. And the way I did that, weirdly, was I ended up going to university full time. I still had Stuart, he was 4 when we lost Martin. So I was working as a dinner lady during the university holidays. I was studying full time. I had a family. I used to do my essays on a Saturday night when my husband was working nights. So my mum would have my son, and I would just work through the night, do my essays, have a sleep on a Sunday, so that come Monday morning, I was ready to do everything else. And that's how I went for many years later. In 2001, I had Tom. I was 40 having Tom. And in 2003, I had an ectopic pregnancy. From the time I had an ectopic pregnancy, there was nothing normal about my periods. They were completely and utterly irrational. So in 2010, when I bled for 6 months non-stop and ended up having an emergency operation after having pints and pints of blood and iron pumped into me, and came out of hospital having had fibroids removed, and I spiraled into a deep depression where I sat for 6 months in a pink anorak with a hood up in my living room, being told, literally rocking in a chair. I told my doctor, and I told myself and everyone around me, that because it was the first time in my life since losing Martin that I'd had to stop because I was physically and emotionally unable of doing anything, that I'd had a nervous breakdown. I was on diazepam in the beginning, I was on Valium, I eventually ended up on antidepressants. And about 6 months in, I started to balance a bit. I didn't need the anorak anymore. I mean, I think I didn't burn the anorak until 2 years ago, but I was better, but never ever fully recovered. And I did have success. I went from being a wreck to working for an MP to actually becoming an MP and having successful campaigns. My very first thing within 6 months of becoming an MP was convincing all the governments in the UK to introduce a children's funeral fund so that no parent, like I couldn't afford my son's funeral, that no parent would ever need to worry about that again. So I had success, but I lived to work. I went into the House of Commons, I did what I had to do, I went back to my flat, I went to sleep. I woke up, went into the work, came out. During this time, I'd been asked to take on the role of Shadow Women and Equalities Minister. And women started coming to me and asking me to give them a profile on elements of a menopause campaign. They were working in silos, but one wanted better medical training so that doctors could understand what the menopause was. We discovered that 41% of medical schools did not have menopause on the teaching curriculum. And another wanted posters put into GP surgeries with the symptoms on, so that at least women who were going back and forth the doctor for umpteen appointments for different ailments may actually make a link and prompt the doctor to make a link. And I give them the platform. And we would talk and we'd have a cup of coffee. And at this time, I still thought I'd had a nervous breakdown. And I was talking to these women, and they started talking about their symptoms. And suddenly I realized that I hadn't had a nervous breakdown. I had hit peak menopause. I never told my doctor. Every time I got up off a chair, I'd say, oh God, age don't come alone, because every limb in my body was aching. I never told my doctor that I had itchy skin, or I had a migraine, or that I had to go and lay under an open window naked. There's an image you won't get out of your mind all day now. I'm feeling physically sick. I never told my doctor that I sometimes felt that I thought I was going insane because I couldn't remember things. I never told my doctor any of these things because I didn't think they mattered. And one thing I'd add to that is, up until that point, not one of my friends had ever had a menopause. Not one of them. Some had had nervous breakdowns, some had suspected fibromyalgia, some of them had suspected insomnia, but none of them had had a menopause. And when I actually went on the UK primetime TV, a program called Loose Women, and said I was menopausal, my friends phoned me up and said, you were posh having a menopause. Because menopause was something that white middle-class women could afford to have because they could go to a private doctor and get a tablet or a cream or a lotion for it. Working-class women like me and my friends, we didn't have time for a menopause. We didn't know what it was. And we certainly couldn't take a time off work. And if you went to your doctor, he didn't know what it was either. So
it was always a he, right?
No, it was a woman as well. And young women doctors were the worst, interestingly. None of them refused me now, by the way. So I started to give these women a platform and then suddenly realized I was menopausal. And you know, literally, it was a light bulb going off in my mind. And I thought, my God, how many other women are like me have spent their life thinking they've got mental health problems to discover that they're menopausal. But I still didn't do anything about it. I owned it, so I didn't let it control my life mentally, but physically it did. It had a grip on me because I didn't have the energy. I didn't have I would avoid going on holidays because I didn't want the hassle of packing a bag, unpacking a bag, doing the washing, getting on a plane, being responsible. It was all too much for me. And it wasn't until 2021 when in the UK Parliament we have something called private members' bills. And they are when you get, literally, it's a raffle. It's like everything else in bloody politics. It's all a raffle. But there's a raffle and they pick out these bowls from a glass bowl with numbers on, 1 to 20. There's 650 MPs. The top 20 are guaranteed to have a day in the chamber. And I came out at number 3. It was just as COVID was ending. Just before COVID had started, I got it in my mind I was going to start an all-party parliamentary group on menopause. And we were going to look at the aspects of menopause and try to do something to convince the government to change the way it thought about women's health. So I win this private members bill, I get number 3, and I think, right, what am I going to do? I didn't care what I did as long as it gave menopause the attention it needed, the political attention it needed. I thought, right, we'll go for mandatory workplace policies, then realised that we couldn't do that because it would be too many government departments, it would take too long, and there's no one policy that works for every woman. Every menopause is different, every woman is different, every environment is different. Then I thought, right, we're going to go for mandatory training for GPs. Realised that that was down to the medical schools, not the government. So we thought of all these weird and wonderful things. And I live in Wales, where we've got a devolved parliament, and we don't pay for prescriptions. Neither do you pay for prescriptions in Scotland, nor Northern Ireland. So I'm with a friend in the tea room in Westminster who says she's going to pick up her prescription, and it's going to cost her £40. That's about $50 US. And I say, what do you mean you're going to pay for your prescription? And it suddenly dawned on me. Women in England were paying for HRT. Women in Wales, Northern Ireland and Scotland weren't. I'm going to ask the government to give women in England free HRT. Now, it was a hard battle, and I didn't win it in its entirety because they wouldn't give it free. But what they did do, as a consolation, if you like, they give the prepayment certificate to all women who applied for it. So all their HRT products, except for testosterone, that's another story, for one annual fee of £20 a year.
And I am a living example of it, by the way. So thank you very much, Carol. I had no idea.
But Carol, the whole point of it wasn't about bringing up HRT, because I believe every woman should do what she wants to cope with her own menopause. What I did was to give parliamentary attention and political momentum to a really important issue. After that, we were talking about it in the House of Commons. I was applying for debates. We were getting men talking about it. We were having men telling us their wives and their mothers and their sisters and their brothers' story. Suddenly, we're all talking menopause. And now, It's literally a national conversation. There's a lot of work to be done on it, and I know you're going to ask me about that, so I will stop in a minute. But we are, I mean, I'm now a government member of parliament, not an opposition member. But in opposition, I was starting to get the government into the right place. With the new government, who are my party, I have definitely got the government in the right place. And with the health being devolved in Wales, they will do it first, because I'll make sure they do. But it was a grassroots campaign, and women who have a presence on media, who put themselves out there and spoke about menopause publicly, that suddenly every woman now realises nothing to be ashamed of. Businesses will keep wonderful women. Marriages will stay together. I mean, the stats I could give you are mind-blowing. But now women...
Karen, I'm sorry, I'm going to stop you there. But before I ask questions, can I please ask for a round of applause for Carolyn? Because this is really, it's a fantastic story of real action and pushing really at the highest level, at a national level. We were asked at the beginning of this session to think about actions, small actions and big actions. Let's take a leaf out of this book. I think it's tremendous. I'm going to ask each one of you a really quick question, because I think there are some questions in the audience as well. But Ginny, I'm going to come to you first. And it's actually a question inspired by something that Carolyn said. The NIH has done an amazing job with moving the needle on research reporting, and then creating that awareness where it all starts with research, data gathering and data collection. Are you working with other funders? Are you working in other funding constituencies, if you like, to share the knowledge, the experience, the tools that you've created, so the same can happen elsewhere, where research happens elsewhere?
Thanks so much for that question. I need
If
to
you speak, that will...
Okay, thanks so much for that question, and really highlighting Carolyn's wonderful remarks. We are happy to work with many, many other folks, and we are. In fact, we highlighted our work with colleagues around the globe in a publication where we compared our approaches. Actually, the first author for that paper is in the audience, Jamie White. And we compared our approaches, and we took different approaches. The Canadians included sex and gender from the outset. We started with sex as a biological variable. Another approach was taken in Korea. So we publicized those to share our experiences and to try to understand which aspects of those approaches worked and why. Because as has been highlighted earlier today, there's so many different contexts around the world. And in the end, achieving the goal is what's most important, and having a variety of tools and policies are just one of those.
That's terrific, thank you. And Carolyn, what about you? Are you thinking of taking it more globally? You talked about the UK broadly.
I'm quite happy to go global. It's always been my aim in life, to be global. But talking collectively, I mean, it's not just a health issue for women. This is domestic violence, worse for women with menopause. Yes. It can bring on domestic violence because of the relationship. Marriages break up. Criminal justice system. You know, I had these made to take into women's prisons, just the symptoms on, so that women who have not got access to online resources would actually have access to what the symptoms are. I spoke with the Sentencing Council. They now admit that there is very likely that there are women in prison who are there because of their menopause. And I can give you a real-life story from February of this year, when I went with Davina McCall into a women's prison in Gloucester, where I met two women, both of whom were in prison. One had been, two of them had been driving vehicles, never been in trouble with the police, but driving vehicles, lost concentration, and when they lost concentration, they knocked down pedestrians. Both pedestrians died. They were sentenced and charged with death by dangerous driving, both serving 5-year sentences. It was a menopause brain fog. They just lost it for seconds. And the consequences were they've lost 5 years of their life in prison, and somebody else has lost their life entirely.
I think that's a great example of the far-reaching consequences, right? It really is. We're talking about menopause. If it was somehow a self-contained time in life also, that also takes a long time, but it touches on so many aspects of the whole society, not just, of course, individuals in question. We have time for one question. There's a question over there. Go ahead,
Can you see me? Hi, my name is Roberta Maranjo. I'm a junior investigator, have a lab here at Cornell, Weill Cornell Medicine in New York City. Yes, can you hear me? Okay, sorry. So I'm a junior investigator. I have a lab here at Weill Cornell Medicine in New York City. And what we do, we study menopause and the influence on brain disorders like Parkinson's and Alzheimer's disease. So my question is for the whole panel, but specifically for Dr. Clayton. So obtaining funding up until now has been kind of challenging because of lack of funding, of lack of interest, of lack of understanding of the importance of studying sex differences and menopause. And some of the biggest challenges I faced, this is my experience, but I think other colleagues can confirm, is that although I'm grateful that NIH asked the investigators and everybody to include sex as a biological variable, the reviewers and people still do not understand of the importance. So the challenge in obtaining funding is also in getting the reviewers understanding the significance of what you're trying to do. So sometimes my grants come back saying, this is not important. Oh, I always have males. I always have males, females in menopause. Everybody's included. Nobody's left out. But it's the significance, it's that gap that it's missing right now. And I really hope we can work towards that. I think it's great that we're getting additional funding. I'm grateful to the president, to the first lady for that. But I think if the reviewers do not understand the importance, the grants will not get funded.
Great question. Quick answer?
Sure. So I'm really excited to share with you that one of the pillars of the initiative is galvanizing research on midlife health of women. So I've been able to, as a result of that, have conversations I hadn't had before. Last week, I spoke at the National Institute on Aging's Council, which is their external advisors, who are the peer reviewers. The reviewers are us. They're the scientific community. And there is a need for further education so people understand that accounting for sex as a biological variable includes thinking about female-specific issues, and justifying female-only studies is part of SABV. Scientific justification is appropriate. Menopause is a critical health inflection point for women, including for the onset and development of chronic diseases like some of the ones that you study. It's an incredible opportunity to make a difference in that woman's life. So we are working together through that Pathways of Prevention program I mentioned and other strategies to expand that understanding across the institutes and centers at NIH. Thanks so much for that question.
Thank you very much. I think this was a really inspirational panel. We spanned many aspects, ranging from the very origins of research design, through to healthcare, through to the community engagement that we also talked about in the morning session. Plenty of inspiration for action, both small, each going back to the very beginning of our session today, small actions, small steps that each one of us can take, but also longer term. If you remember, Brian talked about setting up collaborations. Well, I encourage you to talk to the panelists, and to me perhaps, to set up collaborations. Thank you so much, Janine. Thank you so much, Carolyn. That was terrific. Thank you.